Welcome to AETCM, the Emergency Medicine channel.
Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIIMS Kochi, and he is Dr. Ebin Thomas, MD resident second year. So we are going to discuss about a case about a paracetamol overdose today. Start.
A 30-year-old male presented to ER with alleged history of deliberate self-harm by ingestion of tab paracetamol at around 6 p.m. on 24th of this last month. Coming to initial 10-second assessment, the patient was conscious, oriented and obeying commands. Coming to airway appears patent, no secretions. Coming to breathing, air entry bilaterally equal, respiratory rate of 20 breaths per minute, saturation of 98% in room air. Coming to circulation, BP of 130/80 millimeters of mercury, pulse rate of 80 per minute. Coming to disability, GCS of E4, V5, M6, pupil bilaterally equally reacting to light. Coming to exposure, temperature 98.6 degree Fahrenheit with a GRPS of 130 milligram per deciliter. Coming to adjuncts of primary survey, we took a VBG which showed a pH of 7.40, PCO2 of 45 and bicarb of 24. No acute acid-base disorders as such. We took an ECG showing normal sinus rhythm and no QTC prolongation. Coming to ambulatory history, a 30-year-old male presented to ER with alleged history of deliberate self-harm by ingestion of tab paracetamol approximately 80 tablets on 24th of last month at around 6 p.m. He was taken to outside hospital around 7 p.m. where he was given gastric lavage and charcoal wash, and the patient was started on N-acetylcysteine and referred to here for further management after 6 hours. On arrival, there was no history of any cough, vomiting, nausea, anorexia, no altered behavior, no history of any abdominal pain or loss of consciousness. The patient did not give any history of any co-ingestions also. Coming to medical history, the patient was a known case of psychiatric illness but not on any medications as such, on improper treatment. Coming to past history, no history of any similar attempts in the past. Coming to the last meal was taken at around 5 p.m. Coming to examination, general examination was no pallor, no icterus, no cyanosis, clubbing or generalized lymphadenopathy or pedal edema. Coming to systemic examination, CNS, GCS was E4, V5, M6, pupil bilaterally equally reacting to light, moving all four limbs and no focal neurological deficit. Coming to GIT, the abdomen was soft, non-tender, bowel sounds were present. Respiratory system, air entry bilaterally equally reacting to light, equal and no added sounds, normal vesicular breath sounds. Other systems were within normal limits. Our provisional diagnosis was a stage 1 paracetamol overdose.
Okay. So the history here, this is an event which has happened. Okay. It happened on 24th at 6 p.m. Last month at 6 p.m. And the patient presented here after, at the bottom?
6 hours. 12 around.
After 6 hours. Okay. So coming to that event, so you should know, the history should be according to that who approach. That who saw it, when it happened, who saw it, when it happened, why they think it happened, what happened before the event, what happened during the event, and also what happened after the event. When was it consumed? Was there any why he consumed the same thing? Because is it because of any psychiatric problem or anything? And what happened before the event means what sort of tablet it was? Was it tablet or was it
tablet paracetamol
650 milligrams?
650
How many tablets?
80 mg as he says. 650 milligram of tablet. 80 tablets.
80 tablets of 650 mg means it is significant.
Yes.
It will anyway cause toxic. What is the toxic dose of paracetamol?
Single injection of around 200 to 250 milligram per kilogram or more than 12 gram in about 12, 24
That is,
hour period.
that is 50 mg per kg in pediatrics, children.
Single injection.
More than 12 gram
In a 24 hour period in
24 hour period in adults is likely to cause paracetamol toxicity. Okay. So that is a toxic dose anyway. It's more than 12 grams. So whether what happened, like simply after that, was it mixed with any other tablet or?
no, sir. He claims the incident is not seen by any bystanders. He himself claims that he had taken 80 tablets. The bystanders noticed paracetamol packets which were open, and they asked him, and they told like that the patient conveys that he has taken 80 tablets, like that. Sir. No history of any co-injections, anything like that. Sir.
If at all it is a paracetamol toxicity, it will not cause immediate death. Okay, so it's a delayed. The toxin action takes place after some time only. So the primary survey is anyway clear. You're not suspecting anything in paracetamol in this poisoning. Okay, once you go to the secondary survey only, you come to know that. Once you go to the ample history only, you come to know that this is a case of alleged history of paracetamol overdose of 80 tablets. Okay. That too after 6. Usually paracetamol, once it is consumed, it reaches your stomach, and the absorption takes place within 1 to 2 hours. From the stomach as well as from the duodenum. Complete absorption within 1 to 2 hours. And if the presentation is within that time, within one hour or so, you can actually give
gastric lavage.
Gastric lavage, actually, practically speaking, you can give gastric lavage, but as per the theory, in UpToDate and all, they have written just activated charcoal. Okay, because it's a water soluble drug. So you can give gastric lavage, but as per the theory, if you check in various textbooks, they have written just activated charcoal, 1 gram per kg or maximum 50 grams. And before that, you will have to aspirate samples for, if it is presentation is within 1 hour, gastric samples. But blood sample, when will you take?
At the end of 4 hours.
Yeah, blood sample you shouldn't be taking at the initial arrival itself. After 4 hours only, it gets the peaking of the paracetamol level happens inside your blood. Okay, so you can do that thing. Do the initial decontamination process, including gastric lavage, activated charcoal, and then okay, no other co-ingestants.
Yes, no other co-ingestion.
Okay, so you're not expecting any problem in A, B, C, D, or E. Okay, but when you assess the case of poisoning, you should think about other possible poisons also. What all poisons will affect their A, B, C, D, E. So specifically, we'll be looking for in A, if there is any secretions or anything of that sort, because in OP poisons and all these things, airway will be compromised. So here that is clear. So then B, any wheezing is there, that also OP poisoning will cause. And then C, is there any hypotension? Nothing is there. Even beta blocker poisoning, calcium channel blocker poisoning, all these things will affect the C. D, you'll have to check GRBS, GRBS, all these hypoglycemia can occur in beta blocker overdose, OHA overdose and all. Then GCS, see whether the patient is in an excited state or in a depressed state. Depending on that, if the patient is in an excited state, you'll have to think about anticholinergics, sympathomimetics, all these things. But if it is in a depressed state, you'll have to think about cholinergic agents, sympatholytic agents. Okay, so in that case, you'll be thinking in terms of the toxidromes. Okay, so whether the patient is depressed or excited. So you'll get to know what all the possible poisons are. In this case, that is not affected at all. Patient is completely conscious oriented. Okay, because paracetamol is not going to cause any immediate CNS or any serious manifestations. Basically, it attacks the liver, and after some time only this paracetamol, the liver toxicity happens, and finally it will go to liver failure, then renal failure, then severe metabolic acidosis, arrest. So immediate death won't happen. Okay. So that is about GRBS, then GCS, then pupils. In all poisoning cases, you'll have to check the pupils, whether it's pinpoint or whether it's dilated. Okay, that gives a clue as to what the poison could be. If it is a patient is excited state with dilated pupils, then you should have to think about what atropine, things like that. Okay, anticholinergics agents. Or if it is a pinpoint pupil, OP poisoning, or even opioid toxicity. Okay, but in opioid toxicity, the respiratory rate will be affected. So in respiratory, if in B itself, you'll get to know that if the respiratory rate is below a normal value, then you should be thinking about opioid overdose. And now we are in D, right? GRBS, GCS, pupils, and lateralizing signs, where the patient is moving all limbs and all. Then exposure wise, expose the patient and then see for the skin, whether there are excessive secretions suggestive of organophosphate poisoning. But if it is a patient is very much dry, hot, flushed, then think about atropine poisoning or some mushroom poisoning. Several things are there, and maybe cyanosis, some other poisoning, some like asphyxiants, carbon monoxide, cyanide poisoning. Okay, that's a separate group. So in between you took ABG also. So ABG is fine. VBG is fine. So no lactic acidosis. So what all drugs can cause lactic acidosis? Any idea?
One is alcohol itself, metformin.
Metformin, ethylene glycol, methanol overdose, carbon monoxide, cyanide, all these things asphyxiants can cause lactic acidosis. Then methemoglobin, everything, that part is also fine. But when you analyze VBG, you should check each and everything: PO2, PCO2, bicarb, lactate, methemoglobin, carbon monoxide. Okay. So then only you'll get to know what the poison could be. Blindly, just because the patient told he took paracetamol, doesn't necessarily mean that it is true, or doesn't necessarily mean that he hasn't consumed anything else other than paracetamol. Maybe it's a mixture of several items. So that classical paracetamol presentation you may not get in all cases. Maybe it's a mixed case. Okay. Okay. So this patient presented to a local hospital, and they did a gastric lavage within 1 hour. Samples they would have already taken, and patient reached here at 6 hours after consumption of paracetamol. So now your task is, patient is fully stable otherwise. So now your task is to draw blood samples, right? So how did you manage the case?
Initially, we have sent the blood samples, sir. Sent all the routine investigations, including the RFT, LFT, INR.
Now, one more thing. In history taking, your history taking is not complete. All systems should be like, who saw it? I told who saw it, when it happened, where it happened, like how did it happen? Like, is it a single dose or staggered dose? What happened before the event, during the event, after the event? Then you should go system wise, like CNS manifestations. Okay, is there any any CNS manifestations? Normally in toxins and all we see for sensorium, whether the sensorium is low or high. That is one thing you look for, especially in a case of poisoning. And then whether there is any tremors, any myoclonus, fasciculations, all these kind of things. Even in CNS examination, you should be addressing those things: fasciculations, tremors, clonus, and all the pupils and all these things. And then CVS, you'll have to address any syncope, bradycardia, those kind of things, because it could be toxin. Specifically, if you are thinking just solely about paracetamol, these are not doesn't carry much of an importance. But if you think in a broad way, you have to specifically ask CNS questions, CVS questions, RS questions, GIT, what all things, specifically in the case of poisoning.
The abdominal pain, right hypochondrial
Abdominal pain can be there. And then what? Bowel movements. Especially in these things and all. Anticholinergics and all. Bowel movements will be restricted. And then bladder is palpable or not. Because urine output will be reduced. Whether bladder is palpable or not. Okay. So GIT, genitourinary, then skin and miscellaneous. Temperature is normal, right? In this case. Okay. So this is a fairly easy case. Within 6 hours presentation. Okay. So how if the patient had come to you within 1 hour, you would have given?
We would give a gastric lavage and activated charcoal.
Activated charcoal. Okay. When is a gastric lavage contraindicated? Acid, alkali consumption, hydrocarbons. Okay. And then if some lithium or like arsenic and consumption and all. And when is activated charcoal? If there is some ileus, there is forward movement is of this thing is restricted, or if it, maybe some things like arsenic, lithium and all will not be absorbed by activated charcoal. In that case, it is contraindicated. Okay. So this one presented at 6 hours after consumption. You took blood serum paracetamol levels, and if immediately you get, tell me how to manage it.
We have sent within 1 hour. If the patient arrives, then we will do the gastric lavage, and also we will give activated charcoal, and we will send the samples, gastric samples, everything for toxicology screening also we will send. And at the end of 4 hours, we will send the serum paracetamol levels. The antidote for paracetamol poisoning is N-acetylcysteine. The indication is that if the patient has taken any, suspecting any toxic dose, and if the serum paracetamol level is not available within the next 8 hours.
So as per this history, patient has consumed a history of toxic consumption, so immediately start N-acetylcysteine. You have got two protocols. One is the IV protocol, the other one is the oral protocol. So what is the IV protocol, right?
We follow the 21 hour
IV protocol.
So it is like 150 mg per kg in 5% dextrose 200 ml over 15 to 60 minutes NAC infusion, followed by 50 mg per kg in 5% dextrose 500 ml over 4 hours, and then followed by 100 mg per kg 5% dextrose in 1000 ml over the next 16 hours.
Okay, so 150, 50 and 100. Okay, over 1 hour, 4 hour, 16 hours. 5% dextrose. Okay, so that is the IV protocol. And what about oral? If the patient is not willing for IV, this thing, you can give an option for oral.
We will give 140 mg per kg
as 72 hour protocol. So it's not 21 hour. Okay.
140 mg per kg as a start dose. Then we will give every 4th hourly. Maximum 17 doses can be given at the rate of
70 mg per kg.
70 mg per kg.
Initially start is 140 mg per kg. And then 70 mg per kg.
4th hourly.
4th hourly.
Maximum 17 doses.
And that will be over in 72 hours. So that is the oral protocol. Okay. So this patient you probably started on?
NAC infusion was started.
NAC infusion. And okay. And okay. So how how is paracetamol going to affect your body? Like, if they consume too much of paracetamol, what will happen?
Normally, paracetamol is metabolized like by conjugation, sir, and small toxic doses. Initially, by conjugation, it will metabolize into glucuronide and sulfate, sir, and small amount of the toxic poison, that is N-acetyl parabenzoyl will be formed by cytochrome 450, and that is metabolized by the glutathione into cysteine and mercapturic acid. If you are taking a toxic level, or in patients where there is glutathione is severely depleted to more than 2/3, in those patients a large amount of N-acetyl parabenzoyl will be formed, and this glutathione deficiency also there, and since large amount of N-acetyl parabenzoyl is formed, that will causes the toxic doses and causes binds to the cellular proteins and causes centrilobular necrosis.
So your idea is to give
Replenish.
NAPKI, which is a precursor of glutathione, right?
Yes.
And then prevent that this thing, NAPKI, from causing hepatocellular necrosis. So we initially started this thing. Okay. And when was the paracetamol level available? Like, was it available immediately?
No, so after 6 hours the patient came. Yeah, that time still we have sent the paracetamol levels, but also we have started NAC infusion.
But paracetamol levels didn't come on time.
No, come on times.
Because it comes between 4 and 24 hours. The graph is like that. So it starts from 4 hours to 24 hours. So if you get the paracetamol, serum paracetamol levels within the first 24 hours, will you be able to plot the paracetamol value in the graph, right? So this one was available probably like after 24 hours, and now there's no point getting. If it was immediately available, you could have easily decided whether to continue whether to initiate NAC infusion or to stop NAC infusion. In this case, you will have to anyway follow the routine protocol, 21-hour NAC. So, suppose the patient has already taken a dose of NAC from outside hospital, 21-hour protocol is already over, and now he presented to you. So, will you continue NAC, or
based on the parameters of INR and AST, we will look. If the INR is less than 2, AST is within normal limits, then we can think of stopping the NAC.
No need to. If the INR is more than 2,
and we need to continue NAC.
Continue. So what dose?
6.25 mg per kg
per hour. Okay. Okay, then?
The patient was then admitted and observed, sir. Serum paracetamol came, and that was also within normal limits. We monitored the patient for
This one was in stage 1.
Stage 1.
So what are the stages of paracetamol toxicity?
Basically, we divide it into 4 stages, sir. In the stage 1, the presentation is within 24 hours. The symptoms will be nausea, anorexia, malaise, vomiting, like that, sir. In stage 2, it is 24 to 72 hours, sir. 1 to 3 days. The patient presents the right upper quadrant pain and abdominal tenderness, like that, sir. In stage 3, the patient...
this AST will be elevated. If you check the lab values, in that stage AST will be elevated. Okay. Stage 3?
In stage 3, the patient goes into hepatic failure, hypoglycemia, lactate abnormalities, coagulopathies, and the patient can even land in death.
So major thing happens in stage 3 basically, including death. It happens in stage 3, affecting all the LFT, coagulopathy, and even renal failure and all these things.
The patient
if the patient survives
stage
3, he goes into stage 4. Okay, so that is a period of recovery, stage 4, right? So okay, then
And these are the 4 stages, sir. In this patient, the patient has went into recovery stage, sir.
Recovery stage.
We have referred to the psychiatry also took the patient take over, sir.
Okay. So when will you decide whether to refer the patient to a liver specialist or not?
If the patient develops, meets the worsening of the liver function, sir, develops signs of coagulopathy,
So basically, you apply the King's
College criteria, where there is pH for acetaminophen toxicity, where there is pH less than 7.3 or lactate more than 3, or there is all the 3 criteria like hepatic income of stage 3 or stage 4, or INR more than 6.5 with a creatinine of more than 3.4. If this criteria is met, then definitely the patient will be taken for transplant.
Okay. The lactate more than 3, that is, they have mentioned like despite fluid resuscitation. 3 or 3.5, just find it out. Despite fluid resuscitation, if the lactate continues to remain more than 3, then it's a criteria. I think one more thing, that phosphate and also is considered in certain. The value of phosphate. I forgot the value. Just find it out. Anything more? So, summarizing, once you consume paracetamol, it gets absorbed to your circulation within 1 to 2 hours completely. It goes to your liver, gets metabolized to non-toxic products, and also by glutathione. But if the glutathione gets depleted to such an extent that it is not able to metabolize, it will cause produce toxic metabolites such as NAPK, and that will cause hepatocellular necrosis. So to prevent that, if the patient presents to you in the initial phase, then you can give N-acetylcysteine, which is a precursor of glutathione, and that will detoxify this thing. And depending on the stages of paracetamol toxicity, the stages of paracetamol toxicity are stage 1, 2, 3, 4. Depending on the presentation, you can classify. Stage 3 is the most worrisome stage, and if the patient is able to survive stage 3, he'll go into stage 4, which is a period of recovery. So the NAC infusion protocol, either it could be an IV protocol or a oral protocol. IV is preferable, but if the patient is denying IV, you can start on 72-hour oral protocol also. And after 24 hours, you repeat the INR value. If the INR continues to remain more than 2, you continue the NAC infusion at 6.25 mg per kg per hour. And depending on other lab values like creatinine, INR, the initial presentation, hepatic encephalopathy, grade 3 or 4 is there or not, and then phosphate values, lactate values, and all these things, you apply the King's College criteria and decide whether the patient should be referred to a liver specialist or not. So what other toxins, this is basically liver, this thing causes liver toxicity. So what other toxins will cause liver damage?
Alcohol itself can cause, and then antitubercular therapy.
Methanol, ATT. Okay. Certain mushrooms can cause liver damage. Certain heavy metals can also cause liver damage. So anything more? Okay, thank you.